Biacuplasty, disc herniation, and DiscFx procedures in discogenic low back pain. First and foremost, we condemn the barbaric Zionist Nazi attack on our Palestinian people and stand with the people of Gaza to support them, and we mourn the lives of Palestinians who were ruthlessly killed by barbaric savages. When we are talking about the pain, we are talking about the pathology first, the origin and the cause of pain. The cause of pain may be spinal pain, may be musculoskeletal pain, may be cancer, and may be also cranial pain. For spinal pain, there are multiple types of spinal pain. Maybe radicular, discogenic, facetogenic, sacroiliac, instability due to spondylolisthesis, vertebral fractures or vertebral masses, muscles of the back, neural canal stenosis, paravertebral masses, filled back syndrome, and also the causes of musculoskeletal pain may be arthritic pain, post-traumatic, post-operative pain, malignant lesions, benign neoplastic lesions like osteodystioma, benign osteolytic lesions like aneurysmal bone cyst or giant cell tumor. And for the cancer pain, there is craniofacial, thoracic, upper abdominal, and pelvic. And for the cranial pain, the most common causes are headache and cranial neuralgia. For discogenic low back pain, it is one of the types of often missed in diagnosis and in management for low back pain. Not all causes of back pain are truly discogenic. It may be a mix of many types. So what are the criteria to diagnose the discogenic pain? Maybe pain with sitting for too long, difficulty or pain with forward bending, muscle spasm in the neck or arm when you do upper or lower body movement, pain in affected area, weakness in the distribution of the nerve roots maybe, and increased back pain with coughing, sneezing, laughing, and straining, and also numbness, pains, and needles, and increase in leg pain with straining, coughing, sneezing. It also is indicative, but there is no typical examination for determination of the discogenic pain. Some consider biphasic straightening from flexion and indication of problems with discus. Pain from pressure on the spinous is considered as an indication for discogenic pain. What is the examination? When the patient is sitting on the table and his back on the therapist, and the therapist pushes down towards the patient's shoulder, and if he provokes the pain, we can consider it positive for discogenic pain. So, what are the treatment methods? We are doing 3 different techniques: the annuloplasty and the nucleoplasty and the annulonucleoplasty. For annuloplasty, you are doing biacuplasty and intradiscal electrotherapy. For nucleoplasty, we are doing coblation and percutaneous discectomy. And for annulonucleoplasty with the recent procedures, it's a DiscFx procedure. So, what are the inclusion criteria to treat discogenic pain by a minimal invasive therapy? Number 1, functional limiting low back pain at least 6 months duration, lack of satisfactory improvement on previous sessions of injection or medication or physiotherapy, normal finding on neurologic examination, negative results of straight leg raising test, MRI scan that don't main compromise any neurological compressive changes like disc migration or severe neural canal stenosis, and also in some institutions they do first the provocative discography, which is maybe obsolete in most of institutions. So the first technique is intradiscal biacuplasty. It is to treat mainly the bipolar radiofrequency of the annulus fibrosus to treat the annular tear. We started doing biacuplasty since 4 years or 5 years with a series of more than 50 patients. So it's considered one of the largest series in the Middle East in our institution. And we did an IRB approved clinical trial on 22 patients with satisfactory results about to be published. In this technique, we are doing the procedure by radiofrequency needle. You can see the needle is directed here in this. This is a triangle when we can consider for biacuplasty the position of the needle here to be in the junction between the annulus and the disc nucleus fibrosus, and there's a rotation of the CR or angiosuite. This is the position in Scotty dog appearance. You can see this here. This is better. You can see here the needle, the first needle. This is the active tip of the needle here. It's 2 centimeters. You can see this. This is the advanced needle, advancing the needle, and then we are doing advancement to the second needle. This is the second needle here. To the other side by local anesthesia first, then we pierce, make a penetration for the second side, contralateral side, to make the tips together and make 1 to 2 centimeters of the tips to make a bipolar radio frequency power to make ablation for the nerve roots in the annulus fibrosis to treat the pain which is due to annular tear. And this is another video of one of our cases. This is a triangle. You can see this is the position where the patient under local anesthesia, and this is also the rotational movement of the tube. You know, this is maybe some instability in this patient due to spasmic tube muscles. And this is one of the studies about the improvement in 1 to 3 to 6 months follow-up for intradiscal biacuplasty. The second technique is intradiscal electrothermal therapy. When the patient under local anesthesia, 17 gauge thin-walled needle was placed under fluoroscopic guidance. And this is a demonstration for a case. And this is a needle which make a rotation inside. You can see this is the needle here. And this is a catheter inside the junction between the annulus fibrosus and the disc, and we can make a degree for 90 Celsius over a period of 13 minutes and maintained by 90 Celsius for 4 minutes in the catheter temperature to make a sealing or make its power to ablate the nerve index in the annulus. And this is the technique, the procedure under local anesthesia. And this is one of the studies about intradiscal electrothermal therapy. The third technique is coblation therapy. It's one of the techniques of the nucleoplasty. It's the second category. So we finished the first category, which is the annuloplasty, which is concluded by acuplasty and intradiscal thermal therapy, and this is the coblation therapy. We started since 10 years, and with different manufacturers, and satisfactory results were conducted. But in more, we doing it in true back pain. It is not an evaporation of the disc. It is only to make intradiscal heating, to make the shrinkage power, which can decrease the pressure inside the disc. Following insertion of the coblation bipolar device, 6 channels were made at the 2, 4, 6, 8, and 10 and 12 o'clock position to ensure the adequate compression of the facet. And this is one of our cases for this, and this is, you can see, this is the movement of the needle here inside the nucleus pulposus. Don't ablate the annulus here, ablate only the nucleus. And for the side of the MRI proved disc bulge or herniation, which should be contained disc herniation. And this is one of the studies of the visibility of the coblation nucleoplasty. Number 4 technique was percutaneous discectomy. Percutaneous discectomy is to make a discectomy mechanical aspiration of the nucleus pulposus. The combination of the new device and the dual guidance, like in this publication by Professor Nicola Amoretti in Nice, is similar to other percutaneous devices in achieving the mechanical decompression of the disc. The goal of this combined technique is to create a space, like an oval space around the probe, allowing to decrease the pressure inside the hernia. These are 2 systematic reviews about the feasibility of percutaneous discectomy, and this is a technique when we make the CT guides and the fluoroscopic guidance together. The device, which is called the herniectomy, is composed of an introducing cannula with a side window 1 centimeter in length. It fits inside a suction system motorized probe connected to a collector The motorized component is linked to an Archimedean screw, and the rotational frequency of the screw allows mechanical reduction in viscosity of the herniated disc. And we can imagine the use of CT for this to make a three-dimensional study and to make an interlaminar approach also to make to reach this. You can see this is a neural canal, and this is a line injected to push the neural canal to the other side, and this is the herniated disc to make a CT-guided herniectomy. It is similar to the endoscopic technique, but it's more easier than the endoscopic technique, but we can consider it as an approved technique also. Number 5 technique is called annulonucleoplasty. It is the technique of herniectomy, radiofrequency. It's just called DiscFx procedure. With the progressive development of minimally invasive surgical technique and instrumentation, the DiscFx technique for the manufactured electrons in USA, a system of fluoroscopically guided nucleus bulbosus removal, radiofrequency, and annuloplasty, 3-in-1 technique. Discectomy, radiofrequency ablation, and annuloplasty together. And is gradually being introduced in the clinical practice. We can call it the alternative to endoscopy or the step before endoscopy. So when we are treating the discogenic pain, we can consider injection first, then annuloplasty, nucleoplasty, then herniectomy and radiofrequency is called the DiscFx technique, and then number 4, Olasty technique, which is endoscopic discectomy. So for this technique under fluoroscopic guidance, the skin, and the end, this is a video. You can see this video. Under fluoroscopic assistance, the skin entrance location was indicated. Then the pathological side was choosing this approach. You can see this is here, the needle here, and they make exchange by Zelldenker technique through the campaign triangle. But in this technique, we are doing more angulation of the needle to make it more to the posterior side of the disc. It's not like the first technique by Biacuplasty when we make the tip of the needle in the anterior junction between anterior 1/3 and posterior 2/3, and this is the tip of the needle shouldn't exceed in lateral view the junction between posterior 1/3 and the anterior 2/3. It's contra to the other location. And this is the fragmentation by the forceps to the disc. The cannula introduced through a guide wire over an annular in anteroposterior and lateral views. A pair of grabbing forceps was used for manual discectomy, and the deceased disc was removed separately. Then first radiofrequency of 1.5 megahertz was used to ablate the nucleus. Bulbosus a bipolar turbo mode for ablation, and we can see this. The power of ablation make a shrinkage power to decrease the intradiscal pressure, and also to make a sealing power to kill the nerve endings causing discogenic pain in the annulus, especially in the posterior annulus, by 4 megahertz, about 4 megahertz. Then the 4 megahertz power, which is safe also to the neural canal. And this is one of our techniques, one of demonstration of 2 or 3 cases collected together, and we can see this is the needle here. We can see this is a forceps. We make a removal of the forceps inside the annulus, and this is the fragments of the disc, and this is some fragments of the disc. Then we are doing intradiscal radiofrequency here. This is a team after one of our operations. This is a disc fragment to the patient. For all disc procedures, minimal invasive procedures, patients were given a lumbar corset press to wear for 1 month. This was intended to deter movement, and that might elevate the intradiscal pressure. Patients was also given a profile that restricted then physical training for 6 months. Then also were permitted to walk and to do gentle leg stretches immediately after the procedure. After the first month, graded exercises and stretches were allowed. In conclusion, interventional radiology can give a good alternative option for many conditions in patients suffering from severe and intractable pain. Minimal invasive treatments provide alternative for discogenic pain with the appeal of cost-effective, possibly less long-term side effects, faster recovery, less operative time, less surgery-related trauma, and less significant pain and fewer complications. Thank you.
Thank you, Dr. Ahmed Awad.